All right, I just heard a talk on the elbow recently, and I guess I hadn't really thought about it, but early in training or early in experience, I think the elbow is a little intimidating because we just don't see that many of them. But the speaker was saying, and I think the more elbows you see, the more you realize this is actually one of the easier joints that we image, and we'll talk about that. There aren't that many things to look at, and the pathology is relatively limited. So let's take a look. First, what we're going to do is look at normal anatomy, as is usually my custom. And then going to look a little bit, Laura touched on this, talking about the labrum, but looking at the throwing motion and where do we look for injuries in the elbow. And there's three areas you want to focus on. And then finally, going to look at distal biceps. We just saw some proximal biceps pathology. We're going to look at the distal biceps in the elbow and what type of spectrum of pathology are we going to see there. So here we go, starting with normal anatomy. My basic search pattern for the elbow just goes inside out, starting with the bones, also cartilage there, but looking at ligaments, tendons, nerves, muscles, and other soft tissues, and that's how we're going to start with anatomy. Now, we all know the bones, obviously. What I want to do is just talk for a moment about what attaches where on the bones. And so on the medial epicondyle, we get the common flexor tendon. Just below that, along the undersurface, we have the footprint for the proximal ulnar collateral ligament. As we go laterally, we have the common extensor tendon, and then I don't know anatomically if it's true, but on MR, I look at the attachment of the lateral collateral and lateral ulnar collateral as being kind of a conjoined attachment in there. Now we have the coronoid fossa to receive the coronoid in full flexion, the capitellum and trochlea, and then we've got the large olecranon fossa posteriorly. The radius is pretty simple. We basically are talking about the biceps tendon attaching at the bicipital tuberosity. And then the ulna, lots of attachments here. So let's take a look. First, the brachialis is going to come down kind of on the down slope and a little distal to that on the coronoid. Along the ulnar aspect of the coronoid, the sublime tubercle, sweet name, is where the ulnar collateral ligament is going to attach. And then if you think about the proximal radial ulnar joint, we saw the distal radial ulnar joint with Dr. Resnick, but proximally, you've got the round radial head and the concave sigmoid notch, and around that we have the annular ligament attaching both along its volar and dorsal aspects. The supinator crest right below that on the ulna is where your lateral ulnar collateral ligament is going to come behind the radial head and attach to the ulna. And then certainly the triceps on the olecranon. All right, so just a couple pitfalls. Every elbow lecture pretty much starts with this one, and that is the pseudo defect of the capitellum. I can't imagine most people are not familiar with this, but it looks like there's some type of irregular osteochondral defect there. But if you just cross-reference on your sagittal, you see we're going through that non-articular portion of the capitellum, which will often be opposed by cartilage on the radius when the elbow is in full extension. So on a coronal image, that can be a little problematic. Another one that you see occasionally, here's a T1 non-fat-sat image, is this little, looks like a piece of bone there. You think, well, what's that doing in the cartilage? And you may see that as a very dark, almost like a loose body on the fat-sat images. But if you look at the olecranon, this is the most common kind of pattern of the cartilage on the olecranon, and you'll see this little valley between the two pads of cartilage, and that's filled with fat. And so it's not that uncommon on your sagittal images to see what looks like potentially a little piece of bone or loose body in that region. All right, moving now from the bones to the ligaments. The ulnar collateral ligament, as we know, is the primary ligamentous stabilizer of the elbow. And so the anterior bundle, shown here by Netter, is the strongest component. We'll go over and over the fact that that's your primary restraint against valgus forces. The posterior bundle I want to emphasize because, as I'll show you, we sometimes will see injuries more isolated to that. And that really goes from that medial epicondyle down along the edge of the olecranon and forms the floor of the cubital tunnel. And then the transverse ligament, I don't even think about because it goes ulna to ulna and really has no real stabilizing function that we know of. So anterior bundle on MR is what we see classically for most of the slices where we go through here. You can see it attaches firmly to that sublime tubercle. There should not be any fluid or contrast. There was an article that came out years ago about maybe in older patients we start to see that strip away, but I've heard the author say, well, maybe we were a little generous with that. In general, you should not see any fluid or contrast going between the distal ulnar collateral ligament and the sublime tubercle. If you notice on a T1 weighted image on this arthrogram, there's some increased kind of intermediate signal in the proximal fibers. And that's something that we see commonly. Again, it's just a mild pitfall. I don't think any of us are going to confuse that. But when you're doing a non-arthrogram, sometimes on a STIR or FATSAT T2 image, it can look a little bit brighter, but usually the fibers will still appear to be intact. Now, this is one thing I really want to emphasize, and that is when we look at the axial images, and David was just talking about using, what do you use your different images for? Just like in the knee, I primarily almost now use the axial images to look at my ligaments and my tendons because you get less volume averaging there. Same thing here, when you're looking at the ulnar collateral ligament. On the axial images, at this level, you're seeing the posterior bundle coming down to the olecranon there. You'll notice, as I said, that forms the floor of the cubital tunnel with the ulnar neurovascular structures right next door. So that's your posterior bundle. As we go distally, you can see now the thicker anterior bundle and how those two will fuse as we come down to the coronoid, the sublime tubercle. So when I'm looking at an elbow, if I have any question on those coronal images, and in fact, even if I don't have a question, I'll usually follow it up looking on the axials to make sure that both of those bundles look normal. Now laterally, again, a little bit like those dorsal extrinsic ligaments on the wrist, these are more kind of thickenings of the capsule, but we do see what look like discrete ligaments on MR and on the cadaver. So we've got the radial or lateral collateral ligament, we've got the lateral ulnar collateral ligament, and then we've got the annular ligament. All right, so if we look, I always find my common extensor tendon and look just beneath that on the more ventral or volar cuts, and you'll usually see that little radial collateral ligament along the undersurface of the common extensor tendon. As we go more posteriorly, you can see that lateral ulnar collateral ligament coming around behind the radial head, and as we'll see, that's going to be very important for stability of the lateral aspect of the joint. And then on your sagittal scans, you can see the annular ligament. But again, these kind of all blend together. And so we look kind of at all three of these when we're going through that lateral side. So here, let's take a look now, putting it all together as we come on the lateral side. So here we've got a common extensor tendon there. And then just underneath it now, I see this little curvilinear dark structure as the radial or lateral collateral ligament. Now, as we go more posteriorly, we're going to start to transition here into that lateral ulnar collateral ligament coming down to that supinator crest on the ulna. All right, what do we got here? We're still in the lateral joint under the radial or lateral collateral ligament. I'm sure many of you know that this is a plica, like we see in the knee and so forth. But there is a beautiful article I would call your attention to in AJR in 2013. This is a diagram taken from that. And you can see that they show how this all goes together because people talk about different plica and so forth. But the bottom line is some people believe that this plica can actually result in what's called a synovial fold or synovial fringe syndrome and cause pain. Now, this was a 19-year-old gymnast who came in with lateral-sided pain. And you can see, unlike the normal plica I just showed you, this one extends well into the joint on this coronal image. And on the sagittal image, you can see some of the subsynovial fat coming in where that plica seems to be extending into the joint. I got very excited. We called this probably synovial fringe, and I recently looked back after a year or so reading this, and they gave him an injection, got better. That's it. So anyway, sometimes they may actually have to go beyond if the injection doesn't do it, but keep an eye on this little plica over there. If it extends more than halfway across that joint, you might want to say that that could be or if it's thickened, and there's nice articles out there, if it's thickened, then this could be a cause for lateral-sided symptoms. Tendons we're all pretty familiar with, triceps. We got brachialis, which like the teres minor is almost all muscle down to the bone, very little bit of tendon. Biceps, just to remember that on our MRs, usually it's in an oblique plane sagittally, so we don't see the distal very well. And that's why on every elbow, be sure that they got the axial scans down through the bicipital or radial tuberosity, because you can miss distal pathology on other images. All right, the common extensor, common flexor. So here we go, biceps. The long head lies laterally, the short head lies medially. And then we've got the lacertus fibrosis or bicipital aponeurosis, which tends to stabilize the biceps, and we'll see that when we look at pathology. If we look distally, you'll notice they kind of transpose. The short head goes distally, the long head is here. Now, sometimes, and I know I've seen ultrasound talks where they'll notice one of the heads is torn. Usually, most cases, we're just looking at the whole tendon, not necessarily the individual heads. And so here we go. It's in a more transverse orientation as we come out of the biceps muscle. Very nice to see that area on ultrasound. And as it comes down distally, you see the brachialis behind it, and you see the bicipital aponeurosis coming across the top. And you'll notice on a sagittal scan, you should see the biceps and brachialis right in front of and behind each other. As we come distally, they diverge. So here comes the biceps over to the radial tuberosity, the brachialis coming on that downslope of the coronoid. And then finally, common extensor, common flexor tendons, lateral and medial epicondyles. As I mentioned, we see those well on both axial and coronal. And then finally, the nerves. We know the big one we look for is going to be the ulnar nerve in the cubital tunnel. It has a small retinaculum forming the roof, and remember again, the posterior bundle forming the floor. All right, here we've got what? Accessory anconeus, or anconius, or however you want to say it, causing some compression of the ulnar nerve, a cause for ulnar neuritis. All right, so here we have a normal ulnar nerve, and I want to draw your attention, as you come into the proximal forearm, it's always surrounded by fat. So we'll look at how that might help. So what's wrong with this image? Anybody? Something's missing, right? So ulnar nerve is there. What have they probably had done? Transposition, very good. Here you can see transposing it out of the cubital tunnel. Now they can put it subcutaneous, submuscular, or even intramuscular. So what am I supposed to do when I'm reading here? It's like, well, what here is it? Well, the trick that I use when I see that is to go down, come distally, go into the forearm, and notice now I can see it nice and surrounded by fat right there. Now I'm going to go backwards, and in this case you can see it's just a subcutaneous transposition, but boy, I could have thought that was just a vein easily. Radial, we'll look for at the level of the radial head. You should see both the deep and superficial branches coming through that radial tunnel. And don't forget, the deep branch is going to go through the supinator at the arcade of Froge for you eponym fans. And then finally, the median nerve, it's way over here between the heads of the pronator and under that bicipital aponeurosis. All right, let's talk about a few minutes about elbow mechanics. We know it's a hinge joint, but it also has rotation for supination and pronation at that proximal radial-ulnar joint. Now here again, this is Laura was talking about the throwing motion, and so if we look from wind up all the way through ball release and follow through, we've got these various stages it's been broken into. And it's in this stage between late cocking and acceleration where she was saying how rapidly the arm moves and the kind of forces that are applied there, and that's where you have maximal valgus forces. So what we're talking about is that during that throwing motion between late cocking and acceleration, you get pull on the elbow laterally. All right, so here we're looking on the anterior and posterior aspects. All right, well, what's that going to do? Medially, that's going to put any medial-sided structures under tension. So ulnar collateral ligament, ulnar nerve, common flexor tendon. What about laterally? We're going to start to see maybe some compressive injuries on the lateral side because of that force. And the one that I never knew for many years is you've got to look posteromedially, because as the arm is pulled that way, you get shear forces here as the ulna kind of slides over, and you'll get cartilaginous problems in that posteromedial joint. All right, so those are the three areas you've got to emphasize looking at in any kind of a thrower or overhead athlete. All right, let's get into some cases now. These are just kind of random, but they're fun. And so we got a 21-year-old baseball pitcher at our college who experienced sudden onset of pain while throwing. He was tender over his medial elbow. All right, so there's our MR arthrogram. And I will say we do a fair amount of arthrography, but it's usually in these athletes because they want to look for very subtle changes here. So give you a moment to look at this. All right, so what are the findings here? All right, well, I think most of you saw the ulnar collateral ligament tear, and on just a single image, it looks like there are a few fibers perhaps still attached, but there's certainly a lot of contrast and fluid undercutting that. So we've got edema in the adjacent muscle, so a pretty high-grade ulnar collateral ligament tear distally. This is the area that I was telling you about, easy to miss. because I never looked there for many years. But this is where you're going to see cartilage loss or osteophyte formation, and it can be really critical in terms of what they do surgically. All right, so let's take a look. Our diagnosis here is an ulnar collateral ligament tear and a posteromedial cartilage loss as part of that 3-component valgus overload syndrome. So we got 2 out of the 3 here. Now you can tear your UCL with the fall on an outstretched arm, like just for traumatic, but it's often this chronic attenuation. And again, those valgus forces create that kind of degeneration, micro tears, which can go on to more significant tears in the thrower's elbow. A complete tear is the most common, okay? But in our athletes, we see a lot of partial tears. And here on this arthrogram, you can see our 19-year-old baseball pitcher, medial elbow pain. Again, looks very much like the first case that we looked at, but here's that T sign, okay? So the sideways T showing that undersurface partial thickness tearing, in this case, almost full thickness, but that's hard for them to see at surgery. So it's a very important diagnosis on our end. Don't forget the posterior bundle. Here's one of our college pitchers came in. Take a look at the anterior band. And the anterior bundle looks pretty darn good. It's attaching to the sublime tubercle. But as we went posterior, we noticed all this soft tissue edema. I don't know, there's some signal in the anterior band there. But then we got back here and it was like, what? So this is one of the first cases where I thought, well, let's look on the axials. Sure enough, when we looked on the axials, the anterior band's not completely healthy. But this was primarily, as we went through all of our images, partial tearing of that posterior bundle. And we had 2 cases almost in a row, and we thought, well, this is great. Maybe these guys can get back into action sooner. And it turned out this was just as nagging often as an anterior bundle, but we have a very limited number of these. But when you have any question, go to your axials. All right, here we have a skeletally immature pitcher, 14 years old with medial elbow pain. That's his non-throwing arm and his throwing arm. I think many of you probably see this. All right, so we've got widening of that apophysis, all right, and it's asymmetric. Here's the MR. Okay, I'll let you look for just a moment. Well, you can see the ulnar collateral ligament actually looks good, but the problem is in the apophysis. And I'm sure most of you already made the diagnosis here of medial apophysitis, or sometimes called epiphyseolysis because of the plain film findings, and a little leaguer's elbow. And what's the story is that little, skeletally immature, the weak point is always going to be that physis, okay? And so here, when they have that lateral, valgus force, often the ligament is okay in these kids. It's really the bone is taking the brunt of the problem. And then finally, the posteromedial joint. Again, you can get shear forces, develop osteophytes and cartilage loss. So we're going to focus on that area in these elbows. And you can see on this arthrogram a little bit of subtle subchondral sclerosis there. And sometimes that's all you're going to see. Here on the T2 FATSAT, you can see some edema in that posterior trochlea. But then here's one where you can see clearly cartilage loss there and some subchondral edema, maybe early osteophyte formation. Here's another picture. You can think all of our pitchers are injured, but these are over years. Okay, so 20-year-old pitcher. Even on this, the ulnar collateral ligament looks fine, but look at that spur. We got a little osteophyte going there. Ulnar collateral ligament looked pretty good until we got back here. And again, as David just emphasized, use your plain film because this looked like it was an old avulsion of the sublime tubercle. He'd had a medial-sided injury then. And then here, look on his axials, the size of these osteophytes. Now, what lives right next door? Your ulnar nerve. And you can imagine over time, these patients may develop ulnar neuritis either due to stretch of the nerve or, as in this case, due to these types of large posteromedial osteophytes. Case number 2 is a 15-year-old baseball player, 4-year history of elbow pain, recent episode of locking, tender over lateral aspect of the elbow. So he came in, got a radiograph, and then an MR arthrogram. So here's the radiograph. Okay. There's the arthrogram. Yeah. Not what you want at that age. All right, so going back to the radiograph, I'm sure everybody saw that subchondral lucency, fairly well defined, but also some fragmentation in that region. Then we go to the MR and you see the fragmentation along the anterior surface of the capitellum. And when we look on the sagittal images, we see this fragment with fluid and contrast undercutting it here indicating that is not a stable fragment. And you can see you already had one unstable fragment that became a loose body. So in this case, we've got the osteochondral lesion due to that impaction and shear forces along that radiocapitellar joint. There's typically that anterior capitellum like that. Formerly known as OCD, we now call these osteochondral lesions osteochondral injuries, but the mechanism is that repetitive impaction and shear forces. Now we see this again, like the little leaguers, in kind of adolescence in the developing skeleton, both in throwers and gymnasts, because they're weight bearing on their arms. And here's a 20-year-old gymnast, looks almost identical to our thrower, except she doesn't have the fragmentation. Radiography, we're looking for that subchondral lucency and or fragmentation, but then on the MR, we're going to look for signal abnormality, usually in the capitellum, and we see that nicely there. In her case, she also got an arthrogram, and you can see she's got some perhaps cartilage thinning back in this region with a little embedded fragment there, but we don't see any of the contrast getting underneath the fragments, and so we don't see an unstable fragment in this patient. Now, they, as you saw, can go on to loose bodies. Now, this is my favorite case in this section because I think it shows nicely the kind of progression and where this injury comes from. This is a 14-year-old baseball player, and you can see the diffuse edema within the capitellum. What does that look like? Well, Don Resnick showed you some sonk this morning, and to me that looks like a subchondral fracture in that region. And we see the same thing in the distal clavicle, Freiberg's infraction in the foot, and so on. Well, we always have kind of a little humor when we talk about these throwers that come into ortho clinic because they are all amazingly pro prospects, and the parents are there with them. They want to get this kid back in the game because they want a scholarship. Well, he didn't rest long enough, I guess, because here at age 17, notice at about the level of that old fracture line, we now have that subchondral fragmentation. Very, in my mind, pretty similar in terms of that type of sonk type of lesion there with the subchondral fracture. Now, can I prove that? No, but he already had this huge loose body as well. All right, so here we went to surgery. This is the capitellum. You can see the irregularity. Here's the radial head. All right, so they took out the fragment and some loose bodies. And then they did an Oates procedure where they took some osteochondral plugs from the knee. In this case, it was such a large defect, they had to use 4 and do this kind of mosaic plasty there. And hopefully, remember, he's just 17 years old. He's going to be able to function with this. All right, case number 3, guy fell on his outstretched hands while skateboarding. This time he's tender on the lateral aspect and can't really move his elbow very well. All right. I'll let you look for a moment. So we got our coronal and sagittal, that's at T2, and then an axial. All right, findings. Well, I'm sure you saw the bones first, right? So we've got marrow edema, ventral radial head, posterior capitellum. As soon as you see that, what did he do? Dislocated, absolutely. All right, and we'll talk why in just a moment. But that is just like the ACL pattern in the knee. When you see that, you know they had either high-grade subluxation or, in most cases, dislocation. We look on the coronal. You see the malalignment here because look at the tearing of the radial-sided ligaments, where in this case we're kind of transitioning from the radiocollateral into the lateral ulnar collateral, but that whole conjoint area is almost completely torn off. Then as we look on the axial, you see high-grade tearing of that lateral ulnar collateral kind of annular ligament attaching here on the ulna. So the diagnosis here was an elbow dislocation. So this usually occurs, fall on an outstretched hand, not wearing wrist guards here. Come on, parents. All right, so this has been described for years, that these types of injuries usually start on the lateral side and then can propagate through the soft tissues around to the medial side. It's called the circle of Hori. He was actually a graduate student. I looked up this article. It's kind of interesting, got his name in perpetuity. But since we now have the internet, somebody got clever and went to YouTube and looked at a bunch of videos of elbow dislocations. I don't know how they found this many, but using YouTube videos, they saw that depending on which way your body kind of spirals, pronates, supinates, and so on, that sometimes you can actually start the tearing on the ulnar side greater than the lateral. So that's just kind of an interesting fact. But most of the time, it's going to be lateral injuries. So here, what happens? We have an axial load fall on the outstretched arm, and then the supination of the forearm, the radius is trying to spiral out of the joint. Well, what's keeping the radius, in the joint is going to be that lateral ulnar collateral ligament. So that's usually in a more mild case, and they call that stage 1, where we have tearing of that ligament behind the radial head, allowing some subluxation. But then we move on to stage 2. In this case, we've got, they say, an incomplete dislocation, but you can see a couple of important things here. Number 1, the coronoid is the primary bone stabilizer against posterior dislocation, so that's commonly injured. Secondly, you can see why you get the ventral radial head and posterior capitellar contusions or fractures. And then we get higher degree of lateral ligament injury, even capsular injury, as this is starting to dislocate, and stage 3 is a dislocation. All right, so let's look at some imaging here now. Here you can see the fracture of the coronoid. It's truncated here, fragments somewhere in here, as well as the radial head. Now you put that together with an elbow dislocation, you've got what's called the terrible triad of the elbow. Here's another case. Radiography, again, this is one of these tip of the iceberg fractures where you see this, and okay, big deal, little coronoid fracture, but they have a large effusion. When you see this, you have to at least question whether or not they could have had a dislocation as part of this trauma. Now on MR, it's a little easier. Here we have another patient, 56-year-old, multiple falls, most recently 2 weeks ago. You can see she's got abnormal irregularity of her coronoid, probably injured in one of the prior falls, but she's got an acute effusion here. All right, so we go to MR. First thing you notice, contusions, right? This one's a little bit more extensive in the radial head, but that posterior capitellum, classic. What else do we notice? Some contusion in that deformed coronoid. Didn't really fracture, but came close. Then what else? Well, again, just like we saw in that other case, in this case, high grade, we'd have to look on all the images, tearing of the lateral collateral ligaments and lateral ulnar collateral ligament. We've got asymmetric widening of the joint as a result. And then finally, and this is something that you'll notice when you don't have a lot of the other findings and maybe a lot of the edema is going to, on the sagittal images and extension, you get this kind of sag sign, okay? And here you can also see disruption of the capsule and this. This is my favorite history of the day. This guy presented to the ER, and in the medical record it said, and he said, at 1 o'clock in the afternoon, he drank alcohol, smoked marijuana, and did cocaine this morning. Well, that's a busy morning, all right. So he wasn't feeling too much pain, but he fell. Now this guy did a number. What do we see here? All right, first of all, we see some sag, right? Not quite centered on the capitellum. We see, again, some of that capsular. This is going to be that lateral collateral annular ligament area. Looks like some tearing there, capsular injury there, a little bit of contusion there. But look what he did. Here's his lateral, just completely ripped that. But what did he do? All the way around and got his ulnar collateral ligament as well. Good job, good job. He did a great job. All right. I give him kudos for being honest. Case number 4, 2 cases to go here. All right, in this case, came to our orthopedic oncology surgeon for a mass along the ventral aspect of the elbow. They had some vague fullness and discomfort in the antecubital region. There's our axial. Here's a sagittal. It's so dark with the fat sag. This is biceps tendon coming down toward the radius. Here's humerus and olecranon on there. So, diagnosis? I'm sure most of you, yep. Kind of heard a little whisper there. All right, the findings, we've got high-grade tearing of that distal biceps tendon right there. But more than that, we see the mass, all right? And so we've got this lobular, predominantly fluid, but very heterogeneous mass surrounding the biceps tendon in that region. Diagnosis is radiobicipital bursitis. All right, so we see this not that infrequently. Now, remember, the distal biceps doesn't have a tendon sheath, okay? And so if you see fluid in that region, it's probably in this bursa. All right, so now, if you take a look on from the literature, here's that, they call it a bicipital radial. Most of us call it radiobicipital. There's also an interosseous bursa on this side, and you can imagine those help the biceps tendon to glide when you pronate and supinate. All right, so here you can see maybe some tendinosis in the biceps, but you can see the bursa distension there as a cause for pain in this patient. Now, it can mimic tumor, as in our case. It can even impinge, remember at the radial head, that radial nerve is going right through the radial tunnel over here, and if this gets large enough, they can come in with radial nerve symptoms. So here's our patient, and the question is, what's going on inside? Okay, it's a synovial line structure. Could be PVNS, could be synovial chondromatosis, or could be rice bodies again. All right, so we saw this in the earlier lecture in the wrist. Same thing. This is a synovial line structure. We can get that. Here's another one. Rice bodies, synoviochondromatosis. This is the T2 images, again, of radial bicipital bursitis. In this case, there was a lot of fat in this region on T1, and it was just, one of my colleagues called it a lipoma arborescens of the radiobicipital bursa. On path, they just said, the usual synovial hypertrophy, blah, 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 but it's probably subsynovial fat in this chronic bursitis in that region. And there you can see it on fat as well. Couldn't see anything on the radiograph, so it wasn't just ossification. Now, distal biceps. You can have a Popeye from this as well, as David showed us from the proximal biceps. Usually in males, the pathology can be anything, as he showed you in the tendons of the shoulder. And one thing we're going to emphasize is if that bicipital aponeurosis is intact, it may not show a defect here. You won't get the Popeye sign. It can be difficult for them to tell clinically, are they dealing with a partial or complete tear? Tendinosis here looks like tendinosis anywhere. We'll see some thickening, heterogeneity. Here's a different patient, probably starting to get some partial tearing in the tendon. We see fluid signal intensity in that region, a lot of edema around it. Now, partial tears, just like anything else, sometimes they'll form a little bit of scar tissue there. In this case, I would call this a very high-grade distal partial thickness tear with just a few fibers that appear to be intact there. Complete tear, usually pretty straightforward, because here we don't see any tendon where it should be distally, but look at the sagittal on this patient. Retracted, Popeye deformity, and so forth. So that's an easy one. We can tell them how far it's retracted and so forth. But what about this one? All right, sudden pain and tearing sensation when lifting a box. In this case, you can see a nice looking tendon there, but what's going on distally? So we're gonna go to our axial images, right? So we see tendon, something, hematoma, tendon, everything, but we get to our bicipital tuberosity here and nothing. This is a complete tear, but why does it look like that? You already guessed. Because the intact lacertus fibrosis, which we could see on that first axial image, is not allowing it to retract as that other case did. And then just another tendon to keep an eye on, obviously all the tendons, but just lateral epicondylitis, epicondylosis does not look like that. It looks like a partial tear, which it is, of the common extensor tendon. That's pretty much what David's arm looks like. He gave me a compliment, I'll give him one. But if you look at this, it's often in non-tennis players, and if you ever had this, you know how much it hurts. But it's really tearing, usually of the extensor carpi radialis brevis. Doesn't matter, it's partial tearing of that proximal tendon. All right, so here you can see, that should be a nice black tendon. It's gone. Axial images should be a black tendon as the medial common flexor is here, it's gone. I love the parasagittal scans because you can get an idea of how much of that common tendon is involved. One thing to watch for, you may have seen it in this patient as we went by, watch that lateral, collateral and lateral ulnar collateral, because if that's torn or partially torn, they're not going to do as well with injections and with conservative therapy, and the surgeon may want to actually go in and clean this out sooner than later. All right, last case. Case number 5. We'll go through this quickly. All right. Okay, I'm sure you got the idea here. We've got a lot of atrophy in the dorsal musculature in the forearm, fatty atrophy. So we're thinking nerve. What nerve? Remember going through the supinator, we've got that deep branch of the radial nerve, and we've got what? Nice lipoma sitting in the supinator, causing proximal denervation here of the muscles, which became very atrophic. All right, so neuritis, we look for enlargement of the nerve as shown here in the cubital tunnel. Here you can see T2, very, very bright, but sometimes normal nerves can look pretty bright. But here it's clearly enlarged, increased signal, and then look for non-uniform fascicles, even if it's not that enlarged. That's usually a sign of a neuritis. Denervation, as you know, chronic, we get the T1 weighted. It's irreversible at this stage. But earlier, we may see just edema in the first several months, and if they reinnervate at that level, it can be reversible. So here was a patient with Marfan's who had a sudden onset of right hand weakness. They were dropping things and so forth, and here you can see they had no wrist extensors and so on. But here, again, the distribution of part of the radial nerve, you can see this edema. And when you see it in that kind of an anatomic distribution, think of denervation, and here, no atrophy, so this was subacute denervation. We did not find a mass here. Just to finish up, soft tissue masses, if you can give a specific diagnosis, great. But if you can't, you've got to call it indeterminate. So here's clearly a nice lipoma. What about this one? This guy had an increasing size of this mass, a relatively short duration. You can see it's very nonspecific here. I can't call it a cyst. I can't call it a lipoma. I can call it ugly, but that's gadolinium there. Because of his presentation, it was assumed to be infectious in etiology, so they drained it. But for us as imagers, you've got to say it's indeterminate, and I'll show you why in a moment. In this case, they drained it. They got this, which means that. So some cat scratch these. This is a large epitrochlear lymph node. So these epitrochlear nodes, often due to infection, but can be due to malignancy. This was actually a young woman who was incarcerated and came in from the prison with this mass and this MR. So here was T1, pretty cystic or fluid looking on T2, but they did have gadolinium. So again, when something looks cystic, be sure to either do ultrasound or look gadolinium to make sure it's not a cystic appearing solid mass. Here we were ready to do the biopsy. Fellow turned on the color. It was like, but biopsy came back as lymphoma in this epitrochlear node. And then finally, this is where indeterminate comes in. I try not to be a real hero. If I can't tell them exactly what it is. I tried to be a hero here, and you can see this was an outside MR, relatively well circumscribed, high signal mass on T2, and a cubital fossa, 11-year-old. If you look on the coronal image, it almost, it does. It looks like split fat here. Wondered if there was maybe something coming in and out here. Pretty homogeneous there. We said, this is undoubtedly going to be a nerve sheath tumor. Took him to surgery, and it was that. Well, it doesn't make your hand surgeon very happy, so don't try to be a hero there. All right, we went inside out. Remember valgus overload. Medially, ulnar collateral ligament or ulnar nerve. Laterally, the bone changes, and don't forget posteromedially. All right,